thank you for being here for our off-cycle lecture by a special guest. As you all know, we normally do these sessions on a Monday, so I really appreciate you coming out on Thursday? Thursday, right? On a Thursday, all day today, for an old friend, Daniel Wolfson. Daniel has been involved in healthcare in a variety of arenas for decades now. For those of you who follow health policy and health services research, Daniel was involved in the original development of the HEDIS measures. I'll wait for you to say, oh.
Let's see this.
Yeah, so HEDIS was really the first attempt to try and measure quality of care in health plans and health systems. Decades. So Daniel is now the Executive Vice President and the Chief Operating Officer of the ABIM Foundation. ABIM Foundation is a not-for-profit foundation focused on advancing medical professionalism and physician leadership to improve the healthcare system. He's been instrumental in a program which many of you have probably heard of, the Choosing Wisely campaign, and we'll hear a little more about that today. And then I think we're going to hear more about their new program around improving trust in the healthcare system. So I'm going to turn it over to Daniel, who's already mic'd up.
Yes.
Welcome.
I didn't like that old and decades of. It's just like, I don't know. Well, glad to be here. Thank you for having me. I've done the Choosing Wisely talk, hundreds and hundreds of times over 8 years, but I've only given the Building Trust talk about 4 or 5. So bear with me, and I'm going to try to link those two together. So I always ask this question with Choosing Wisely, and I want to ask it today. It's always a great exercise. How many people in this room have seen unnecessary care being delivered, either your family or you? Okay, and then keep your hand raised if you've had people that you know hurt by unnecessary care. When I did, that's a lot. 30,000 people die, according to IOM, from unnecessary care a year. I don't know how they got that number, but I use it. Because unnecessary care does harm people unnecessarily. When I did that same kind of exercise at IHI, almost all people in that room, they're all about patient safety and quality. They all raised their hand, most of them, and most of them kept their hand raised about harm. They see it every day, that's their job. So as was said, the core of what we do at the ABIM Foundation, and I've been there since 2001, is to focus on professionalism. And so we think that professionalism is best demonstrated when it's in action. And that was about why we did Choosing Wisely. That was really the core of it, and that's why we're doing Building Trust. So we always think about the three-legged stool. People use the levers of competition, they use the levers of regulation, but they don't use professionalism as much as we think they should. It's maybe an unused muscle that needs to be exercised more. And when you talk to clinicians, of course, that's their core. And yet in a public policy arena, it doesn't get used. Karen Clancy used to be ARC, now the VA, says professionalism is most important when there's nobody watching. It's late at night, and that is when professionalism, and you can't regulate, you can't possibly think that the marketplace is going to take care of every transaction, every interaction, I should say, between patient and physician in the health system. So that's some background, but I'll go through, these are the, lights are out. Always have to have learning objectives, and those are ours. And so I'm going to talk about Choosing Wisely. It's a relationship to professionalism, and then talk about Building Trust. And kind of the things that we learned through Choosing Wisely. We think we learned a lot, and a lot about how to mobilize people and mobilize a lot of energy and spread. You know, we're real good in healthcare about improving small things, but we're really bad at spread. I don't know why, but we're bad at it. And I think that's what gets us in a state where we are now. So, you know, it was a modest kind of objective. Let's just increase conversations about overuse and prepare physicians and patients to have a conversation. So you probably remember ACA. It was about death panels, and it was about rationing. And we really tried to normalize behavior of physicians thinking about overuse and having those conversations, knowing that nothing was an absolute, that should be conversations. But when there's a lot of noise in the system and you can quiet it down to a patient-physician conversation, it really has power. So I don't know, how many people have seen the physician charter on professionalism besides Matthew? One person? Two people? Three? You are above the percentages of most people that can recognize the physician charter. It was done in 2002. It was in Lancet and in Annals at the same time. It was done by ACP, ABIM Foundation, and the European Federation of Internal Medicine. And it has become our guide in things that we do. We worked on conflicts of interest, and choosing wisely came out of the notion that physicians should be good stewards of resources. It says just distribution of resources, actually. And a big part of the charter was social justice. I think Matthew and I argue about this. We think it makes it different than other documents, and Matthew tells me that's not true, Daniel. It was in the ethics code at the AMA, but we said it last, maybe. Maybe that was what, you know, but it was, to us, it was something novel, that we'd have the principles of patient autonomy, patient welfare, and social justice as its core. And then when we set out to do choosing wisely, we used the principle of simple rules. And that's one of the things I'll keep talking about, is simple rules, where you give people guidelines and you let them discover how to solve problems. And that's what we did in choosing wisely. So this is what it looks like. On the left, it's for the physicians. So another idea that we had was simplicity. This was designed by a communications company. On the left. On the right, it was designed mostly by Consumer Reports at the time. They were our partner. They developed about 80 of these brochures that were for patients, for physicians to pass out at the point of care. They no longer are in healthcare. I don't know if people recognize that, but they pulled out of all of their healthcare products, including Best Buy Drugs, which was really a phenomenal program. That's a long story, but branding is really important. So, and credibility. So on the left-hand side, you have the North American Spine Society, and those are their recommendations. They, you know, we're like Nike. Nike never made a shoe. The ABIM Foundation never made a recommendation, but we collected them and packaged them in a way that I thought was simple. Like, you know, how many things can you remember? 5 things, maybe 3 things. And then having Consumer Reports in the beginning, but then having their expertise was really important as well. It gave us a lot of credibility. So I always say this, it was a messenger, it was the specialty societies, it was the message. We didn't talk about cost. We never wanted to talk about cost. We wanted to talk about quality, safety, and doing no harm. Doing no harm actually was the biggest, most potent message, which we were concerned about because we didn't want to actually push people away from doing what was appropriate. And the other thing that's really important is, what does it say on top? 5 things physicians and patients should question. These are not absolutes. So that was really, really important. So here's some guidance for clinicians and patients, these 5 questions that were developed by Consumer Reports originally. And then on our website, we have clinicians and patients on a mobile app that you can download today. And then patient tools. You know, it wasn't so much that this was a good intervention, but it, you know, giving out educational materials to patients. But what it did was it signaled that it was important conversation and introducing the notion that you could have a conversation about, do I really need that test? And are there other alternatives? And what is the cost? And we got kind of pushback from this, but Consumer Report, and I'm glad it's there now. But we didn't want to talk about cost necessarily. So what's important sometimes is data, but what moves people's hearts is stories. So here's a story. It's my story, and it's not tragic at all. I can still see. But here's two societies saying don't do pre-ops for eye procedures when there's no medical history. Okay, two of them. So I have two detached retinas because I'm myopic and old, and I have two cataracts because when you get detached retinas, your cataracts grow. So on my fourth EKG, which is here, I said to the anesthesiologist, what's the deal? I mean, why did you need? No history changed. I run. You're going to put me under 15 minutes of Lunesta. I mean, come on, it's a cakewalk. I run 45 minutes. He says, I don't want you to be 1 in a million. Well, actually, the cardiologist told me it would be 1 in 10 million. Okay? You'd have to have 10 million EKGs to find one abnormality. And he said, I don't want you to be 1 in. I said, we just can't practice like that. And I mean, how many people are going to get cataract operations in the next 20 years? Massive amount of people. So, you know, it's all about, it's not just the cost of the EKG, they're not costly, but it's the incidental nomas. Okay, and I have another story about my incidental noma, but I won't go through it, but I have cysts in my brain now that have been detected because I had not ringing in my mirrors. What? No, Lunitis. And so I had to get a CT scan, and I now know that I have it. My son, who's out there, probably doesn't know this, that I have a cyst, a massive cyst in my brain that's been there since I was a child. Why did I need to know that? No, I mean, it's just ridiculous. And she actually wanted me, the neurosurgeon, to have a follow-up. I said, well, it's been there. You think it's going to grow in the next 6 months? My ringing in my ear is gone. It was a total incidental moment. So, you know, our success to date was we got a lot of people thinking about this, but here are, you know, some of the numbers. And the number of journal articles has been massive. I get, you know, Google alerts, and every day I get another article about that is mentioned at least choosing wisely. We're now doing a systematic review of all the articles that actually had implementation. We never had an implementation strategy. We thought it would be, the implementation would use traditional quality improvement, and I'll go through some of those, but we never had a secret recipe for how to reduce the implementation. But we did do partnerships. We did a partnership that's still ongoing with Academy Health. We did partnerships with a massive amount of organizations. We're a very small foundation. So anyways, University of Michigan is looking, they've discovered 65 articles where there's been an intervention, and we're still waiting for the results. That's what would be good to know what worked, but really nothing that we provided. But as my president of ABIM says, we gave them an axe, but we're not going to be able to chop down the trees. The healthcare delivery system and the practices are going to have to chop down the trees. We can't. So you know, I think that this is one of some of the things that we learn, the alignment of values and the framing of the issue. I think we framed the issue really well. And we thought about it a lot. We did a lot of focus groups to really think about how to frame. And framing sounds like it's PR, but it's aligning values. How do you know you can trust what we're doing? Are we just doing it because we want to, you know, save money, or are we doing it for quality reasons? And the framing of that is just not PR. It is really a joining of values and motives and objectives. I talked about the simple rules. We saw a lot of bottom-up approaches being done using kind of our philosophy of simple rules, and a lot of junior faculty being involved. It was like a new space that they could enter, and they immediately got it. And there's a lot of examples of junior faculty really taking leadership in this area. And we have another partnership with an organization called Cost of Care, and they've developed something, actually imported it from Canada, called STARS, Students and Training Advocating for Resource Stewardship. And the medical students come together, they go down to Dell for a day in a kind of a round thing like this, and they get knowledge about choosing wisely, but more important, knowledge about leadership. How can a medical student change something in the medical school? Well, they do. They change curriculum, which is just amazing. I mean, you guys know how hard that is, and they've done it. They've done it. Like about 60% of the projects are some kind of change around curriculum. And so, you know, we always think that, you know, culture eats, you know, strategy for lunch, but there has to be some kind of quality improvement. I was baffled that in the beginning we got criticized because some insurance companies came out and said, look, we just measured before and after they came out, nothing changed. My question was, what have you done? Well, you know, promulgation doesn't work because these are habits. And, you know, that's why I think it's so important that we get to the youth quickly, because there's been a lot of studies that show that by the time somebody's done with their residency, they're imprinted with a certain pattern practice. And to change that is very difficult. So you do need reminders. You do need things that will jog the mind and help and hint and cajole people. And I'll go through some of those things, but here they are. So when we looked at, and we had a contract with Robert Wood Johnson Foundation, we were working with 14 large health systems. And if this was an actual intervention, used everything up there for lower back pain. Because lower back pain, imaging for lower back pain is one of the most difficult things. I don't know why, but I think it has to do with pain, right? And I've had lower back pain, and I've been a pretzel. And you want to know that there's something not wrong. So they did every one of those. And there's been a systematic study by Carrie Cola, and her conclusion was that multi-component has to be the thing that works the best. We know that education alone is important, but not sufficient. It's just not going to get you there. Its duration is small. It's hard to transfer it over to the next generation. Unfortunately, to some, clinical decision support is pretty potent. But the most potent thing, and this was another actual random control trial, was peer review, peer comparison. Taking the numbers, people want to get better. It speaks to their professionalism. And it outdid, in a trial, the clinical decision support. And of course, clinical decision support burns out doctors. There is a program, it was developed at Mount Sinai, now it's owned by Premier, and they have about a 50% override. That is, there's false positive, and the doctor says, you know, I'm overriding it. But it saved 35%. And it got applied to 140 of the recommendations. So it had scale, it had impact on the backs of physicians, and they hate it. So I always recommend actually order sets. Order sets are invisible. Take it off the order set. And so that's, I think, just as effective. But I do think that peer comparisons, and everybody knows what academic detailing is. Yes? And it's a sit down and physician to physician or peer to peer talking about your results. You're an outlier. Why did that happen? Let's, you know, I know your patients are sicker, but not really. Not always the case. So I'm going to make this switch now to trust. We're at this for 8 years. And just like we looked at the environment around the ACA, in 2017, we began to look at the environment and saying, where could we be most effective in our professional framework? And when we looked at things, we looked at, and I think I've had it with that slide, but you can read that. But why focus on trust? We saw an incredible erosion of trust that's happening, particularly around this misinformation I'm going to go through, which I think is going to get a lot more important with this virus as we go through our trust in government, our trust in science, and what science says, and when facts are important versus opinions. Today, I read a tweet from a person that used to work at Consumer Reports, and she says that people have this notion that they got to stockpile up on antibiotics, and that tweet is going around on the social media. Holy mackerel. This is a virus, right? So, and we learned a lot about trust in the Choosing Wisely campaign, that you can't have these kind of conversations unless there is trust between the patient and physician. We got very interested in looking at the whole Choosing Wisely from the eyes of disadvantaged populations. We did a lot of focus groups with low-income African Americans and Latino X and white Caucasians, and they felt like there needed to be more trust, and they were very kind of leery of people saying you don't need it. After they gotten access to care, now you say they don't need care. Well, you really need to talk about, and this has been said to us millions of times, and now I believe it, you need to talk about appropriate care. You need to talk about what you need and what's not good for you and what is. So, so that was good. And then we also thought that professionalism, there was a strong link, and a woman who runs a peer support and professional center at Brigham and Women's really talked about the notion of professionalism as being trusted and respectful relationship. Joe Shapiro, who I think visited here. And then there's a connection to ABIM. It's a certifying body, and it's been under attack, warranted and unwarranted. Unwarranted because of its financial condition, which has always been sound, but warranted in the sense that MOC, when it was introduced, was not ready for prime time. And there was a tremendous amount of pushback. And I always say that's, you know, that's not so rare. You know, you wake up and you're at Sloan Kettering, and all of a sudden your chief medical officer has been accused, and was, wasn't accused, he was, having tremendous conflicts of interest, or you're Geisinger and something happens to your ventilation system, or you're in Seattle in Children's Hospital, and you lose trust. So we want to learn how to build trust. Therefore, this kind of campaign that we're talking about building trust. So I don't know if anybody saw this, but if you're interested in misinformation, this was done by RAND, and these were the findings, that there's increasingly disagreement about facts and analytical interpretations of data, and just an anti-science, a blurring of opinion and fact. I talked to the JAMA editor, and he's constantly saying that people write out, you know, they build opinions on opinions. Like you're given, it sounds like it's a fact. You reference something, But in fact, that was an opinion. And then you quote it, and it looks like it's a fact. Drives them nuts, just nuts. And it's for good reason. Here's some, everybody knows this, but false news goes at the speed of light and much quicker than real facts, because they're novel. Usually they're just novel. Like, how can that be? And it gets, how can that be? It gets, accelerated because of, online stuff. I think, it's really changed the speed. So here's some facts about trust. Confidence in medical leaders has dipped since the 60s. Doctors in other countries have higher levels of trust, even though people are satisfied. It's kind of like, do you trust doctors? Maybe. Do you trust your doctor? Of course. It's like, I hate Congress, but I love my congressperson. And there's been a tremendous, we're the biggest loser as far as industries. We're still high, but we've lost 50% from 1975 to 2015. So it's not just politics and vaccines. Articles on cancer. You talk to ASCO, American Society of Clinical Oncology, and they're quite concerned about alternative therapies, alternative facts, and people getting cancer recommendations from that have been discounted by doctors. People are getting their information from family and friends and not news organizations. This guy was a fascinating guy. He would get online all day and do misinformation the entire day. I don't know if you heard about this guy. Amazing. And of course, the epidemic, and by the way, this is not a new slide. This is an old slide. And, trust makes people more likely to adhere to treatment. It makes people more likely to engage with the healthcare innovation, and it helps us respond effectively to public health crises. So if we're in a trust crisis, and now we're going to go through an epidemic or a pandemic, I think we're really, and Ebola in Africa was all about trust. Trust of the government was a major reason why Ebola spread like it did. And not to be politic, but when you announce that the vice president will take over, it's kind of crazy. I mean, I wish that was the head of CDC by his side, which is, a good organization doing great work, needs more resources. So we started a conversation at one of our meetings, and we got like 13 articles published in JAMA. I don't know if anybody saw that. Anybody see these? Well, you can go back online and put trust in healthcare, and they'll all come out. So you can see some of them. We did government, trust in government, trust between patients and organizations. And then one was really interesting. We had one on patient-physician trust, and the patients that were there at the meeting said, I'm worried about my doctor trusting me. If it's self-management you're interested in, and you want us to do more things, you need to trust us. And it was another example of, you want to discharge, a disadvantaged population with antibiotics on a pole, you better trust them, or it's not going to work. And people have had to kind of reevaluate their trust in patients. And then the other one that was kind of unique was physicians, trust in each other. Not much literature on this, but you only have to think about specialty care and primary care and emergency room physicians and people on the floor, and what does that conversation look like? So it was an interesting article. I recommend it highly. There was another article in New England Journal of Medicine by Rich Barron, the CEO of ABIM, the foundation, and they talked about trust in science and the deterioration of science. And so to combat myths and misinformation, it's not always good for you to go out with the facts. It's got to be an unlikely messenger. It's the Republican saying something Democratic, or if it's something Republican, the Democratic. I'm using those polls. It's the unexpected messenger. In vaccinations, it's a woman with a child who has somebody that's autistic but didn't get a vaccination. It's the unexpected messenger. And the science behind that is really bad. And what I've just told you has not been proven to work. It's a theory. It's actually been, put out by somebody credible from the Annenbergs. Jameson, Catherine Jameson, talks about this, but it's not been proven. So we got to the point, and I have some handouts here, we got to the point of saying, okay, what are we going to do about building trust? What can we do? So we said, let's take a chapter out of Choosing Wisely. Let's go to not just the specialty societies, but everyone in the healthcare industry, patients and consumer groups, specialty societies, certifying boards, health plans, health systems. We're going to go to EMR companies. We're not going to go to pharmaceutical companies. We don't trust them. So we did a kind of proof and concept with 68 submissions, 30 practices, and a compendium. If you go online at ABIM Foundation and go to Trust, we have this compendium. We did 8 winners. We featured them. These are featured on Story Slam and Annals right now, where you have their introduction. And we're going to have some interviews as well. So now we're expanding it to this building trust. But here's the categories that came out. We're trying to make trust an intentional behavior. It's usually in the back of our minds. You know, we want people to trust us. We want patients. But let's be more conscious about it. Let's put it as an intentional strategy. There's one clinic, where we have an N of 1 now, called City Block. It was a team that was at the Commonwealth Alliance in Massachusetts. They had 30,000 members forever, and they wanted to really scale it up. They got money from Alphabet, and they're trying to go nationwide now. And they are basing their organization on trust. That is their core principle. Fascinating. So we want people to be more intentional about it, about when they do things in with their EMR, with how they design their buildings. How does it affect the trust of organizations, of people? So this is the categories of practices that came out: communication, knowing your patient, conflicts of interest, conversation and support within the team, misinformation, strategies about that. A lot of people think that fact-checking is helpful, and how scientists speak, what language they use. You know, environmentalists did not speak right about the dangers of climate control. And there's a whole effort now to think about how to speak about that in terms that aren't so shocking, but accurate. Leadership, how leadership purports to give feedback, to have reliable relationships, controls all the kinds of things that an organization does. Transparency and value and affordability. I think one of the biggest trust, trust or trust killers is affordability of healthcare right now. The amount of money being paid by patients. What's that doing to their bottom line? They're going bankrupt. They're also being taken to court. And I think that's an amazingly a mistrust practice. So the goals of this building trust, or to elevate the importance of trust, as I said. Build a community of organizations interested in learning more about this. So we're asking organizations to come forward with practices. Right now we have about 20 organizations signed up, and some of them are umbrella organizations, so they represent a lot of organizations. AAMC is going to do something on the integrity of research. ACCME is going to be doing like conflicts of interest. I mean, if you don't trust the CME provider, they are no longer in business. So that's what we're trying to do right now, and we're trying to be very inclusive. Here's the 5 rules. Focus on your sector is quite key. Don't stay in your lane. Don't tell another sector, unless you have a good practice of how you've worked with a health plan to do something better. So that's it. We think that the building trust will enhance public trust from patients, regulators, the national media, and we're going to build a national platform to demonstrate existing efforts to enhance trust. This is positive deviance, not taking what's not working, but what is working. So that's my talk, and love to hear your questions. Yes. Well, let me take the patient perspective. I mean, what we try to do is build information on both sides, both for the patient to be equipped to ask the questions about overuse, and with the physician equipped with recommendations. The first thing that we did, we worked with a gentleman named Dennis Novak, who has done a lot of communication modules, and we had 10 communication modules by specialty about how to have the conversation about overuse. And, you know, it was things like, this is an option we want to try. If it doesn't work, I'm still here for you. Some kind of, you know, empathy, allegiance to that patient. So that was one thing we did. I'm often asked, and I know this is not exactly your question, but I'm often asked, wasn't there a lot of pushback from patients about this, or aren't they, you know, isn't it attributed to patients that this high overuse? And I don't have good information, good data to tell you. I only have one study, and one study was done in the mid-90s around antibiotics, and they interviewed the patients when they got out of the exam room and said, did you request an antibiotic? Only 1% said they did. So what was happening, the doctor was preempting and assuming that they would ask for an antibiotic, and they didn't want to have the conversation because of time. It was just easier to give them antibiotics. But, you know, issues with, you know, what they would think is withdrawal of care, I think it takes a good relationship, a trusting relationship, a relationship that's got longevity, and has, you know, uses techniques that are good interviewing techniques about anything else. So I think that, you know, my study would be, let's see trained physicians that we can train them with special interviewing techniques and compare them with the ones that don't have it and see what the results are. And that's the study that I'd like to see happen with the ageism. I'm very sensitive to these days. Right. Well, one of the submissions was from a guy, Barry from Mass General, who used to run the Foundation for Healthcare Decision Making, I think. Society for Informed Decision Making. So that was one. I think shared decision making is a tremendous trust builder. So as far as the materials, you know, CDC is at its best when it's partnering with a whole bunch of organizations, and they do that quite well. We've been working with them on antibiotics for a long time, and when they are, you know, when they do campaigns and they are out there, you know, partnering with lots of different organizations, I think they're very effective. And I think, you know, some of their materials have been excellent. So Choosing Wisely is in 20 countries. There's an annual thing going, and Australia, who's really, you know, I know Choosing Wisely might be okay here, but I'll tell you, it's working really well around the world. You know, they've got central claims. They've got, you know, instead of having ARC off in one corner, they have it with the data, and it's amazing. The Netherlands has done amazing work with Choosing Wisely. They did a contest for the best kind of ad for antibiotics, and they were so creative. I think that the, you know, kind of a multimedia approach is really where it's at these days. You know, on TV or on social media, and really being clever. They were just really clever. And if I tell you about it, I won't get it right, and it'll sound chauvinistic, but it was kind of something about, aren't you, a woman saying, aren't you sexy that you don't use antibiotics? It was funny. That's why I shouldn't even said it. I, yeah. So did you see care in our literature? Because I was sitting at Cedar Sinai, and a gentleman raised his hand, and he said, care is never unnecessary. And I didn't get it. And I said, oh my God, we're going to sponge that. We say unnecessary services, unnecessary testing procedures. I totally agree with you. And words do matter. I did. I'll expunge that from my mouth. Thank you for pointing it out. Good question. I You know, probably an ethics question. But if we know, why shouldn't they know? No. It's not equitable that we know and they don't know something. Something that could impact their judgment about my care. I mean, I think that's the problem with conflicts of interest. It distorts physician decision-making. So I think transparency around safety has been successful. And I think it's a very potent, you know, the people in Wisconsin doing their state report cards, Minnesota has done it. I think we need patients involved in change healthcare. And we're not going to do it if they're totally ignorant about the issues. Like, we're not perfect, you know, and the humility, we need more humility. Oh, that was the easy one? Yes. Right. Yeah. Yeah. Right. Fee for service. Right. 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 Well, I agree with you, but just my pushback, like people say, well, it's fee for service. That's really, you know, causing overuse. Or it's just alignment of, you know, there's no alignment, you know, about purpose and values. I get back to the imprinting of physicians from a very young age that determined their use for a long time to come. And if you go to the Kaiser system, which we have worked with, and they have capitation, they're on salary, they have all the incentives of the world to not do anything unnecessary, and they have 25 to 30% overuse. And that's why they built their own medical school, because they were sick and tired of retraining their doctors when they came. So they said, we'll put our money in a medical school, we won't have to retrain them. That's why they did it. And they had to spend some money on social responsibility things. So, so if we had a single payer system tomorrow, do you think that would get rid of overuse? I don't think so. I really don't. And I think we'd be paying on a fee-for-service basis still. That's why I think the word trustworthy is probably a better word, because to be trustworthy means that you've earned the trust, and you have to earn the trust. It's not a given that you will be trusted. And I think that's the good part of the word trustworthy, and it's probably a better word to use. Yes. Right. Right. So I'm going to I'll give you well, it's true. And what you said is totally true. But let me give you an optimistic view. Around this country, patients are being put on boards all the time. In fact, on boards of directors, governance. And in fact, it's a requirement for an ACO that they have to have a Medicare beneficiary on the board, and they have to have a patient and an active patient. So Medicare beneficiary. So those things I think will change it. Then you get a voice. At the ABIM for 75 years, we never had a patient on the board. Now we have 2 patients, and every exam committee, and there's 17 of them, has a patient and a non-physician clinician. So I think that that kind of change will make a voice, because that is the governing body. Too slow, I'm sure. Yep. Right. So I've been pretty vocal. Vitamin D is the case example of the insurance companies not covering vitamin D. And I got to tell you, I'm kind of torn. In the beginning, I said, oh God, you know, vitamin D, you know, it's not a lot of money. It's the screening, not the drug. It's the screening. And that's just going to be the beginning. And these things are to question, they're not absolute. So you're going to do blanket coverage decisions that will adversely impact certain patients, and it'll be costly. They'll be taking it up. But, you know, they're in a bind. I mean, vitamin D screening is just useless. I mean, there's not, I can't think of a condition where you need to screen. I mean, if you think you need it, just take the vitamin D or go out in the sun. So I think they're in a rock and a hard place. The profession didn't get rid of vitamin D. They're still prescribing it after everybody said it. So what are they supposed to do? Continue to pay for something that's totally not useful? Now, I think if it grows beyond that, I think we get in real trouble. But they are in a position where, you know, they have the employers on their backs saying, what are you going to do with costs? You have the public saying, what are you going to do with costs and affordability? And then they make decisions like not cover vitamin D. What are we supposed to say? So I'm a bit torn. I did spend 23 years in HMOs. I come from that background, and they're really in a rock and a hard place. And I think, you know, the first thing that happened with Choosing Wisely is they called us down in the Finance Committee and Ways and Means. And they said, we want to have a public hearing. We said that would ruin the campaign from the get-go. I mean, that is exactly the opposite of what we're trying to do. But now we're 8 years into the campaign, and the stuff is still there. What are you going to do? I don't know. I really don't. Yep. Well, I hope they, as much as the science as possible. My unsatisfying answer, I'm sure, is that it's a conversation between the patient and physician. I don't want one. I don't want a CAT scan of my head, and I don't want to get a redone of it. And that's my decision. And I want the physician to ask me. My neurosurgeon never asked me what do you think about getting a redo? She just wrote it down, and that was it. And that's what made me mad. It was never a conversation with me. I don't want to know. There's things that you, as a patient, I don't want a full body scan. If it was offered to me, I just don't want it. So I think it's a conversation, and and I have to weigh, and you have to weigh, but we both have to weigh. And I don't want to be told what I need a follow-up CAT scan, and I shouldn't have got the CAT scan in the beginning. And I left that physician. I left that physician. She totally lost my trust. It was a new physician for me, and I left him. Yes. Could you use your mic?
There we go. I think part of choosing wisely has to do with tort reform too. So I was I'm a neurologist, and I was at a university for many years, and then private practice, and now I'm here back at the university. Yeah. And I can tell you that it takes time to build trust. And so for those doctors that just prescribed antibiotics because it's easier, I have patients that have headaches, they want an MRI. I talk to them, I do the exam, and it takes me more time to talk them out of the MRI than to just order the MRI. But if there was something, for example, in your case, if you were able to sign something and say that you would never sue the neurosurgeon if something was missed, then that might be a possibility. But it's a big deal out in practice, and I think the trust, in my experience, is much higher when you're a university physician than when you're out in the private practice. And I'm the same person.
So I'm glad you brought up the malpractice. It always gets brought up every time I speak. I have an answer, another unsatisfying answer. If physicians perceive it to be a problem, then it is. That's it. But the facts speak a little differently. When there's malpractice reform, and there's not been a sizable decrease in overuse. So is it a proxy for some of uncertainty? And it's kind of the red herring, let's blame it on malpractice, but really underneath the onion is physicians have different degrees of coping with uncertainty. So I don't know. I like the idea, though, of signing off on I refuse this test and protecting physicians for that. I think it's a great idea.
Could just follow up. So when I was in private practice, I'd get different awards from Cigna, United, because I didn't order tests. So I really utilized, that was a good, in terms of utilization, I really did not order the MRIs. But, there were some cases when I would order, I had one patient that had a kind of an odd Bell's palsy, and she came into me and she had had a CT scan from her internist, and I wanted to repeat it because it was sort of an odd presentation. And I had to go through all of this utilization to order it, all of these different things, and she had a brain tumor. So, I think the trust for physicians in practice, we're really in a tough place in terms of, I really wanted this image for my patient, and I spent a lot of time to obtain it and really get nothing from it other than I'm doing the right thing. So I think that needs to factor into how you're trying to change the system.
I think when the financing of healthcare changes, you will, in essence, be paid for that time. You'll be paid for that 10 minutes, 20 minutes it takes, because the alignment of finances will be correct. So Don Berwick was asked at one of our meetings, he gave a talk and he said, and it was really very controversial, He said, if the patient ultimately wants the test, no matter what I think, I will give them it because I don't want to lose trust of the patient. And as soon as he said that, the head of IOM gets up and says, really? At the time, Harvey Feinberg. And they had this debate about, would you really do that? And it's kind of patient-centered, radical patient-centeredness. Like, I would. And I don't know where I stand on that, but it's a tough place to be. They're leaving. It's not a good sign. But I think it's beyond 12 o'clock. That class, I didn't mean to embarrass you. Yes, you're a couple of minutes over. I want to respect people's time. Yes, please. My son took off. First time he's heard me talk. Ever. Yes. Yeah. Oh. That's probably true, but that's terrible. Yeah. I'm sure it's true. The bankers are around because of that, that's for sure. I'm talking about a person who has an active condition that they're coping with. That's what I mean by a patient, not just a non-physician. A person that has either a chronic condition or, acute onset, on a regular basis. So I think if we want to hear patients, we have to put them on how we design, clinics. And I see that a lot. Patient-centered design is happening in many places. And I hope that's, the future. We're just not going to solve it. We need to co-create. We need to create with patients. And that movement, I think, is beginning to take off. Okay.
Thank you so much.
That's great. Thank you. Thank you for your question.